Hello, yes, so hi everyone. I'm one of the EM and PEM consultants at Adam Brooks. The sessions were initially started for the PEM HSTs in the region and those who've kind of finished their PEM years. And the aim is we just want to provide a regular monthly PEDS related teaching session open to EM Paediatrics, PICU anaesthetics and MDT members, open to ACPs, nurses, pre-hospital. So feel free to share these events in the future. And this morning's topic, we're going to look into dehydration in children. So it tends to be the kind of bread and butter. A lot of your winter presentations may focus on either gastroenteritis or dehydration with bronchiolitis. So a lot of the mainstay of what you may see, especially over the winter and autumn months, may link back to dehydration. And I just wondered if anyone has anything particular they'd like to cover today. So mostly, I think when I first started my PEM rotation, I was kind of trying to get my head around which calculations you use when with fluids. And in terms of this discussion, we're going to focus on interactive cases. So you may need to get a pen and paper just to do some calculations at some point, have a look at the evidence updates, and then we'll kind of go through what we've covered. So a lot of the questions I've come across are, which route are you going to use with your fluids? Is it oral? Is it NG, IV? When you're going to use each of those routes? How much volume? How often? How long for? And which fluid? And throughout the session, we'll refer back to various contradicting guidelines. So some of them are very separate management plans. Some of them contradict each other. There's particularly the NICE guidance, and there's really useful Scottish guidance on particularly gastroenteritis hydration. So the first case is a 3-year-old Pippa. She's 14 kilos and she's had diarrhea and vomiting for 24 hours. She's struggling to keep anything down, and the parents are concerned that she's becoming dehydrated. A lot of the family have DNV as well. Her Pew scores 1 for parental concern, but otherwise her OBS are in normal range. And you want to start a fluid challenge. So I just wonder if anyone can enter into the chat, how much and how often do you want them to give the fluid challenge, for how long, and which fluid? Feel free to keep entering your answers, but you might want to take a picture of this slide or just refer back to it throughout the session. And this is just a summary of kind of the various different calculation options you have. So for the majority of your patients, you're going to have oral fluid challenge on the left, and it's different depending on bronchiolitis versus gastroenteritis. The reason you're going to aim higher with your fluid challenges for gastroenteritis is because of the fluid loss, the fluid deficit that you're trying to replace. Whereas bronchiolitis, you're more just trying to make sure that they can keep hydrated. They haven't got the fluid losses usually. So a rough guide I would use is for bronchiolitis, 0.5 mils per kilo every 10 minutes. Whereas for gastroenteritis, I would initially start at 1 mil per kilo every 10 minutes for 30 minutes, just to get them, see if they can progress on that, and then go up to the target of 2 mils per kilo if they haven't vomited. And that would just be potentially better tolerated than starting straight in at the higher volume. And if you manage to get them at that for a few hours, you're then on track to meet the NICE guidance to confirm they can take 50 mils per kilo over 4 hours. And to clarify, that is specifically for dehydrated children. So children who do have signs of dehydration, but who aren't looking shocked. So if you're, just a reminder, if you've got a shocked, sick patient, you may go straight to IV. And if you're going for 10 mil per kilo boluses, if they're genuinely sick and shocked, that would be a separate plan. If you're then prescribing maintenance fluid, just a reminder of your holiday SIGA formula, more for the EM trainees, because I know a lot of the paediatric trainees will be familiar with this. And just to be aware that if you do end up prescribing for neonates, it's usually a time where you want to discuss with your seniors, get paediatrics involved, because there's a whole separate IV maintenance fluid. The actual fluid type is different, and there's a lot of variation on these volumes, but it changes from day 1 to day 5. So just be aware, not for holiday SIGA for neonates, but we're going to focus mainly on the oral fluids. You can also use these if you are having to move on to NG. You can use these calculations as well on the left. We'll go back to Pippa. So in terms of how to decide if she actually looks dehydrated, if you are aiming for the 50 mil per kilo, there's there's some useful things you can use, just your clinical signs. There's actually a score, whether or not you would find it useful, but if you want some guidance to risk assess if they're actually generally dehydrated, there's the clinical dehydration scale. But the signs are very much what you'd look for on your examination. Are they lethargic, drowsy? Have they got the slightly sunken eyes, or very sunken eyes? That's very subjective what the difference would be. Mucous membranes, are they dry? And even tears, so they actually score if you can see tears, which I thought was interesting. So this patient, Pippa, it started on the fluid challenge, and someone started her on diaurolite or rehydration solution. She says, yuck, she spits it out, it tastes disgusting. Is there anything else you can try?
Amy has put in the chat half apple juice, half water.
Yeah, exactly. And I think it's important to emphasize that it is a diluted mix, half apple juice, half water, rather than pure apple juice. You've got ice lollies as well. Some EDs will have ice lollies, especially in the summer, to get fluid in. And there's quite good evidence for switching from diaurolite in the even as first line, just going straight for the half apple juice, half water combination. So originally diaurolite was actually developed for children with severe dehydration, with cholera. You don't need necessarily that extent of electrolyte rehydration for these mildly dehydrated children who are coming in after a few days of DMV. They've just referenced the study, and there's a nice, don't forget the bubbles summary. I've put the link in here. But basically, this was children who were 6 months to 60 months who'd had more than 3 episodes of diarrhea or vomiting in the preceding 24 hours, but had been less than 96 hours of total symptoms. So we're not talking the severe end of the dehydration spectrum. Their weight was over 8 kilos, and they had just signs of minimal dehydration. So when they compared the electrolyte solution plus an apple flavoring, just so that there was some bias removed from the, change in color, versus the half strength apple juice, that they actually found that it's more likely that the apple juice would be tolerated and outcomes were better. So the primary outcome measure was treatment failure. So did they fail their oral fluid challenge? And I think that's pretty relevant, because that's the main objective, is, trying to get them home, and get them tolerating their fluid challenge. And if they failed the fluid challenge, they either ended up being admitted or having IV, or having to have another physician encounter for the same illness if they had protracted illness, or if the physician requested that they had to cross over groups for clinical reason, or they then developed a higher dehydration score. They then found, we talked about the sort of background to oral rehydration fluids, and basically it determined that although oral rehydration is safe and effective for any degree of dehydration, in the milder cases, it's safe to use apple juice. And so in this case, Pippa vomits twice more despite the apple juice and water combo. What are you going to do next? Yeah, so we've got ondansetron from Charlotte in the chat. And I think there used to be quite a lot of reservation to use ondansetron in children. I think there was a kind of myth that they need to get out the infection and you're going to mask symptoms. But now pretty much most centres have moved to using ondansetron in diarrhea and vomiting, especially if they've failed a fluid challenge. And there's a Cochrane review about managing vomiting in children and young people with gastroenteritis. And they did find it was successful in increasing the proportion who stopped vomiting. It reduced the proportion who needed IV fluids and admission compared with a placebo. But there was a increased incidence of diarrhea. So just to be aware of that. And NICE guidelines also supports this with children who have no red traffic light signs, so they're not looking septic or shocked. They've had 2 or more vomits in the last 4 hours, and they would otherwise be sent to an assessment unit because they've failed a fluid challenge. So then you've got your potential to use ondansetron, but just be aware that's not including children less than 6 months, and just be wary using it with head injury. I think that's the time where you don't want to mask the vomiting. And this is where I would recommend having a read through the Scottish gastroenteritis in children guideline, which actually gives a lot more detail probably than the NICE guideline. So it first of all helps you determine which of its guidelines to use. So some useful things, to remember, that this guideline for rehydration, it's not for children with diabetes mellitus, with metabolic histories, who are on parenteral nutrition or have stomas, not for chronic renal disease. And it asks the question, does the child have bloody diarrhea? If they do, you're then going to go down a different route, looking at bloody diarrhea and hemolytic uremic syndrome guidelines. If there's signs of low sodium, so if they are genuinely very lethargic with decreased conscious level, or they have a history of potential seizure episodes, they've even said if the skin looks doughy, which again is quite subjective, but those are the children where you will want to do bloods, even gas, just to look at the sodium. So I wouldn't include those children in this. And do they have clinical signs of dehydration? So this is going to determine which of the pathways you use on their guideline. So if they have no signs of dehydration, this is quite useful for those over 1 year. I think in our trust, all under 1 year have to be discussed anyway with either an ED consultant or a PEDS reg. But if you're thinking of discharging those over 1 year who aren't low birth weight, who've had less than 5 diarrhea stools in the past 24 hours, and who have had 3 or more vomits, then there's the criteria here for whether you consider a period of observation and reassess after 2 to 3 hours. So this is all doable within the ED. They're tolerating the fluid challenge and you're discharging them with their advice leaflet. If they're not tolerating the fluid challenge, then you're looking again, reassessing, are there signs of shock? And that's when you can move on to either of the other 2 pathways. So that with the signs of clinical dehydration, but no signs of shock, that's where you'll move into considering your oral ondansetron after 2 hours if they've not met their rate to meet the 50 ml per kilo target. Again, at this stage, always with every reassessment, checking for a change, for signs of shock. And it's something where some trusts will have even a nurse-led criteria discharge. So, if you're specifying if they meet their fluid challenge, if they get to this rate, just be clear in your discharge plan. The nurses are experienced at checking for signs of shock as well, just to make sure that there is a reassessment at that stage. And if they then are failing, you're going to end up moving down the pathway. And then if there are signs of shock, if they fail this and there's no signs of shock, you've got your NG option. And then if you do find signs of shock, that's where you're going to move into your alternative pathway. That's where you're going to consider IV access, bloods, 10 ml per kilo boluses. And it gives you some management after that, considering your sodium again as well. So in this case, Pippa does get a sublingual ondansetron wafer. You may hear them called wafers. Some trusts will have just the oral tablets or liquid, and you consider if she's got any risk factors before you discharge her home. So she's not under 1. Fever over 39 is specifically mentioned in the NICE guideline. Again, I would discuss that with seniors, and I wouldn't always keep someone just because of the number of the fever, but I would consider it if it's very high temperature. Have they got the blood or the mucus, any bilious green vomit, any abdo pain or abdo findings, any immunodeficiency or comorbidities, low birth weight, malnutrition, or signs of hyponatremia. And I would just say it's not impossible for a gastroenteritis to trigger an appendicitis. So we've had a few cases where clinically the child had no sign of appendicitis, but just having a gastroenteritis, having an inflamed gut can develop into an appendicitis. So just make sure they're safety netted and aware of the fact things can change. So Pippa gets to go home. For the next case, we've got 8-month-old Omar. He's 8 kilos. He's had a cough, a congested nose, fast breathing. He's not breastfeeding well. He's not had a wet nappy this evening. And his SATs are 90% on air, resps are 50, heart rate 150, and cap breathe fill 2 seconds. His temp's 37. He's got no features of severe respiratory distress. He's got some transmitted upper airway sounds and a global fine wheeze. And just a reminder of the normal ranges at the bottom. His rest rate's on the higher side and his SAT's 90%, as we've seen. So you consider, could this be pneumonia? Has he got signs of sepsis? Could this be something masquerading as a congenital heart disease? So really take care in your A to E exam, checking, for heart sounds, checking for hepatosplenomegaly, checking for femoral pulses being equal, just because it's not impossible to present later. Certain congenital heart disease can present later and can be recurrently diagnosed as bronchiolitis. but you do find there's no other concerning features, and you do think this is bronchiolitis, so you want to start a fluid challenge. So with this patient, just if anyone can put into the chat what you're going to go for with your fluid challenge. I'll put his weight back up. 8 kilos. So we've got from Charlotte, could try oral, may end up needing an NG if continues to feed poorly. And yeah, 0.5 mil per kilo. I think it's a good starting point. Yeah, so we've got a few answers there. And I just wondered, this is a breastfed child. How are you going to approach the fluid challenge? So you're aiming for these volumes, but how are you going to explain that to the parents? And if it's easier, feel free to turn on your mics. So it's tricky with breastfeeding. Personally, I'm not going to, unless I'm really worried about the child and I think they've got signs of severe dehydration, then I'm probably going to actually be more relaxed and let the parents carry on breastfeeding. But I might say shorter times, little and often. You don't want them getting full and getting more short of breath. The main problem will be the shortness of breath when they're feeding, that's limiting their intake. So I might see if the parents want to try smaller and often, shorter breastfeeding episodes, but more often. And it is going to be really difficult to actually measure whether you've reached that target. So I wouldn't necessarily stop a family who are solely breastfeeding from breastfeeding. If it got to a point where, you know, we were really worried about this child and we think they need NG feeding, then that's, you know, they're coming in, they're being admitted. But this is where probably I would relax. And we haven't got the fluid losses that we have with gastroenteritis, so the targets are a bit lower. So often I'll ask the parents the proportion of time they're feeding for. Is it, you know, at least 50% of their usual time? Are they managing that long? Or is it more that they're feeding so often because they're short of breath? It can go either end of the spectrum, but this is where you may have less accurate targets. So the other things that are going to help me decide, do you think this child's going to go home with their observations? If say they do well with their breastfeeding challenge and they manage over 75% of their usual time to breastfeed, they're looking well, but they're still having these observations, do you think this child's going to go home? No. So Charlotte says no. And what were your reasons for that, Charlotte?
So just the saturations and the rest rate at that point, because I don't know how far into his bronchiolitis, but I wouldn't be happy with those obs. I'd be thinking he could go downhill, and especially when he falls asleep, everything might get worse.
Yeah, and I think a period of observation, and I guess the question is how long. And I think you're right, a period of observation during, including an episode of sleep, is quite important. There's a real spectrum of SATS target ranges. So if you're looking at RChem versus NICE guideline, there, you know, RChem often will say above 92. NICE guidelines, I think originally were aiming for 94. So there's a range, and there's an interesting study in the Lancet that actually found we're probably overdoing it. And I don't think practice has changed to reflect that Lancet study. So it's called the BID study. It was back in 2015. And that actually found that if they're maintaining SATs of 90% for 4 hours, including a period of sleep, they're safe to get home. And they actually found they had better outcomes than the children who they were aiming for SATs over, I think 94 in that case. They actually ended up having longer admissions, more time before they got back to their usual feeding, and more complications, which was unexpected. It was a well-designed study. So they managed to blind it by children were either randomized to a group who had modified SATs probes that read at 94 when they were actually at 90, or they were randomized to standard SATs probes. So it's quite interesting because the staff and the family were also blinded to the saturations. And this study wasn't set in an ED, it was set in a you know, PED sort of, I guess it was a assessment unit setting, which not, you know, it may not be completely different to an ED setting, but just be aware it was in that context. But it's, I think, an interesting example that maybe we're treating ourselves, you know, we're reassuring ourselves of these SATs. If there's no sign of severe respiratory distress, we've noted they've got a bit of a high rest rate. It's just worth bearing in mind we may not have to admit these children, and it's, I think it would be a discussion with paediatrics, you know, getting their opinion in that observation period in your 4 hours. If they're going in the wrong direction, then fair enough, you're going to ask for a bed and they'll have a longer observation. But if they're not getting worse, they're not tiring, then consider whether they can get home. And there's actually our local guideline has a cutoff of 60 breaths per minute. So they would actually tolerate a higher rest rate at discharge. And again, the target for their usual volume of fluid with breastfeeding, you're checking they're not having difficulty, that they're, aiming for 75% of their usual time spent breastfeeding, and that they've had 3 wet nappies in 24 hours, or NICE advises just 1 wet nappy within 12 hours. And it is very much dependent on the social situation and if the parents can cope at home with close monitoring. And it's dependent on no comorbidities and no history of apneas, especially apneas can be very, very subtle and not looking tired. And it's certainly not the patients who are wheezing, who are a viral wheeze, who are desaturating. This is the bronchiolitis. And I know sometimes it can be a grey area. So if in doubt with your diagnosis, if you've got a history of sudden onset, shortness of breath, more consistent with bronchospasm rather than a gradual history of shortness of breath, then just this isn't going to be those children who are wheezing and desaturating, because they potentially could deteriorate much quicker. And as Charlotte said, you might bear in mind what time they're at in their history. Is this day 1 and they're going to get worse? But it's just worth bearing in mind that study. I don't know many trusts that are currently strictly using that evidence base, so I don't think it's transferred into practice, but I think it's just worth bearing it in mind.
I just wanted to add that the guidelines are actually changed for bronchiolitis. So above 6 weeks and with no history of congenital heart disease or chronic lung, the threshold is 90 for discharge.
Which guideline was that? Was that NICE, did you say?
It's NICE, yeah. It's changed, I think, last couple of years, like after lots of studies. And it's only in high-risk children, like say, extreme premature or like significant cardiac or respiratory, you can discharge at 90, more than 6 weeks of age.
Oh, thanks, Arundam. That's really useful. Actually, I'll update that then. So that's good to know that although it has actually changed national guidelines, and I'm just still not seeing it in practice that often. But I don't know if anyone else is in other units. Are you seeing that in practice?
In my hospital, it was difficult to change the culture, but now they do agree.
Great. Oh, that's good to know. It's something to keep in mind. And there's just a nice EM3 lightning learning if you want to have a bit more information about that. Have a look at that. So that kind of brings an end to that session. I just wondered if anyone had any specific questions or sort of discussion points they wanted to bring up. So I think, I think a lot of you will be familiar with the fact there's very little intervention. We might suction the nose or use saline drops if that congestion is contributing to their feeding issues. And then there's a lot of debate around who's going to be considered for high flow nasal oxygen, who's going to be considered for CPAP, and again, variation. I think in our trust, we're mainly high flow nasal oxygen, but again, the evidence isn't great for either. Has anyone got any sort of strong feelings about using the high flow nasal or the CPAP?
RPQ are slowly moving away from high flow. Just like you said, as the evidence is not, there's no added benefit to high flow versus normal flow. So they're actually trialing out. I think it's not a formal thing, but they're trialing out normal oxygen versus high flow on PICU here as well.
Yeah, and I guess we're going away from the kind of dehydration topic, but I guess that end of it with the respiratory failure topic is really just going to be supportive, and often you can avoid intervention, but it's just having them closely observed, and especially the younger ones with the apneas. So just be wary of that. Any other questions that anyone had?
I just wanted to ask about, I've had some resistance from parents before for kids with under 1 with DNV, and they've been very insistent that they want to give their child milk rather than water or apple juice. Is there any sort of like evidence I can use or a scientific explanation? Because all I've just been saying is, it we're more likely to make the child throw up.
Yeah, it's a good point, actually. And I don't know if there's specific evidence, again, milk versus an alternative. But I think if they're mildly dehydrated, I would say if they felt really strongly, we could try that with the fluid challenge if they thought it was going to be more successful. But I would explain to them that the evidence base is there for the apple juice versus diluted with water, and that we're more likely to get them home sooner. And I think just highlighting the fact that we're actually prioritizing hydration over nutrition, and that milk may be less well tolerated if they're already feeling sick, they've vomited. But I don't know if anyone else has got any good spiels that they give parents about why not milk.
I think the main issue is that with milk, they develop a temporary lactose intolerance because of the viral illness, which normally takes 24 to 48 hours to resolve. And that is the main criteria because of which we recommend to avoid milk for some time. But end of the day, you need to push in fluids, and whatever the baby is tolerating, we would rather go for that. Yes, I will shy away from concentrated fruit juice because that's high osmolarity and will worsen the diarrhea, because sometimes they might present with vomiting and diarrhea starts later. So even for weaning infants, we say fruit juice should be the last for weaning. So that's the science behind it. But in the developing world where hygiene is a big issue, actually breast milk is the most recommended fluid because they know they won't get access to clean water or so it's a matter of logistics and what pragmatic view basically.
Oh, thanks. That's really helpful.
And I have a question. What's the lowest age you have found evidence for diarrhea to be given?
Yeah, good question. Actually, I haven't done a search for lower age groups, and I don't know if anyone else has come across a lower age limit for when you use diarrhea. I think the study with the apple juice only went down to, I'm just trying to remember. Yeah, it was only down to 6 months, the apple juice trial. So bear that in mind. And I think children especially under 6 weeks, most of those are going to end up with a pediatric review. They're going to have specialist input. Up between that age and 6 months, I think just have that, again, that lower threshold, the higher risk of apnea, just keeping that in mind.
Yeah, as per BNFC, the lowest stage of diarrhea can be 1 month.
Okay. So that was in the BNF, yeah.
Of course, it's not the first choice, but say sometimes you're not getting any cannula and this child will recover. There's no point in keep trying for IV access or, and of course, IO is not recommended. Then why not diarrhea?
Yeah, I think under 4 weeks, that's when I personally as an EM physician wouldn't give diarrhea just because they're so sensitive to electrolyte changes. And I think if they're either breastfeeding or bottle feeding, I would go for that as a first kind of option, first line for a fluid challenge. And often at that age anyway, less than 4 weeks, they're probably going to have a period of observation, and then they may need specific calculations if they are ending up on IV fluid or NG and input in terms of calculating electrolytes and things. So I think that's where I would probably hold off diarrhea in that age group personally. I don't know if anyone else has got any experience with that.
One final question from me. You know that oft repeated criteria, 5 ml every 5 minutes of fluid challenge, which I roughly calculated comes out as the same, the NICE guideline, and you've nicely showed in one of your slides. Is that something you would recommend as per your research? Or?
So I think it would depend on if that's a gastroenteritis fluid challenge or a bronchiolitis fluid challenge. It's a rough figure, but it's more for younger children, I think, whereas if you're older, I would just go for the per kilo calculations. So aiming 2 mils per kilo every 10 minutes for the gastroenteritis where you want to replace their fluid, and then aiming for the 0.5 per kilo per 10 minutes for bottle fed bronch. But I think it's not a bad target for, it covers most of the weight ranges, but I think older children may end up on needing more to replace their deficit. And these are all rough guides. And I think these are really tools for if you need to, you say you've got a very crowded department in the winter and you need a really specific target, so you can potentially use a nurse-led discharge pathway, or you can motivate the parents with a specific target. I think if these are for those patients that are, grey area patients in between, where you want to be sure that they're managing because they're not the most reassuring. The mild ones, I'm going to be less strict about have they got these exact mils, but the ones where they're a borderline, are they coming in or are they going home? And I want to know for sure they're getting their deficit replaced. The gastroenteritis ones, I'll want a specific weight related target. And then there's no confusion for the nursing team as well. And they may feel confident to discharge on a nurse-led discharge plan if they're looking well. So these are tools for, especially winter when you've got a crowded department, your resources are stretched, and thinking about those borderline cases, can you get this patient home safely?
So we'll have to end with your excellent talk. So, you know, I've learned a lot. That's great. Thank you so much for coming. Thank you so much, Josie, for your talk.
No problem. Thanks everyone, and bye. See you.
Thank you.
Bye.
Thanks.
All right.
Bye.
Thank you all. Bye.